The question is about the literature showing in the pediatric surgery literature showing that if you don't visualize the appendix with an ultrasound, that it's and a white count is not significantly elevated, that you can sit back and relax. I've seen that study. One of our surgeons showed me that paper, and it looks pretty compelling. What he basically is saying is, what they are saying is that if you have an inflamed appendix, in general, you should see the inflamed appendix. And if you don't have anything on your ultrasound, the likelihood is that you got a true negative. My concern, and our global concern in the pediatric section, is that is totally dependent on how good your ultrasonographers are. And while in that particular hospital where that study was done, maybe they've got the best ultrasonographers on the planet, but I'm not sure that I'm willing to generalize, and that's the term for in the research world for this. Is that data generalizable to the rest of the population? In other words, can we say because it worked there that it's going to work everywhere else? So for something like antibiotic X against disease Y, and you got 70% improvement, that should be generalizable because the antibiotic is something you can use somewhere else, and the disease is not just in that center, it's in other centers as well. But when you take something that is subjective, like an ultrasound, and say, well, we got this result, and we think based on this result, we can skip doing the rest of the workup, I am very uneasy about that one. If you can show me that once it's been replicated in multiple centers and the data are the same, I think that then I'd be willing to say, yep, this is probably generalizable now. But for that study on its own to say we should be changing our practice and not doing follow-up CTs, I am uneasy with that. And I think, Kevin, you're going to tell us about a study we're going to be looking into.
I don't know if this is actually externally valid elsewhere. I share the same concerns. I think you have to take your pretest probability. If there's a kid that you really think has appendicitis and you get an ultrasound that doesn't visualize the appendix, don't stop. Especially in younger kids, like the toddler age. I mean, that's just a dangerous territory because it's hard to examine them and actually prove that they've got it. If you've got a slightly older kid, you've got an 8-year-old that you can do serial belly exams on, they got no white count, and they can't find the appendix, I'm a lot more likely to believe that. But especially if you're thinking, man, this kid really looks a little sick, don't stop.
Don't forget, if you don't visualize the appendix on ultrasound and you haven't felt the testicle in a male, you better go back and feel that, because that's
absolutely. Yeah. Abdominal pain in males, always examine the testicles and always document it. This is actually from the adult world. In my medical school year, we had a patient that came in, 27 years old, shortness of breath, who was seen by an intern in the ED. Couldn't find out what was wrong with this guy. He didn't have asthma. He gets an x-ray done, a chest x-ray, comes back with cotton wool spots all over his lungs. The resident looks at the x-ray and says to the intern, now go back and finish your exam, meaning do your testicular exam. The guy went in, and this guy had a mass the size of a softball in his testicle. So always, belly pain, shortness of breath. The general exam is part of the physical exam.
I think it's a related question. I had a same case. I've been taught appendicitis is a clinical diagnosis, not a by imaging studies.
How old was the guy that taught you that? Huh? How old was the guy that taught you that? I agree with you. It is a clinical diagnosis, and in the right setting, particularly for males, like you get a 19-year-old male right lower quadrant pain, you get a good exam everywhere, and that's all you got, then yeah, it's probably appendicitis. And so good surgeons are willing to take them there. Increasingly in this day and age, you're getting at least an ultrasound on pretty much everybody. But there's still surgeons out there. I've had 1 or 2 cases in the last few years where the surgeon actually took a male. For women, they almost always want some imaging modality because you can't trust the ovaries in front of you. Like it's not that important to shave 2 hours off the appendicitis diagnosis.
Right. So the question is whether to do an ultrasound or to go straight to CT in kids. A couple things. First of all, we moved to ultrasound here about 2 or 3 years ago. Because the literature does show that there's some pretty good sensitivity in picking up appendicitis, and because you avoid the radiation. And there is a significant amount of radiation with a CT scan. Whether to image or not, whether to go straight to the OR, there are other reasons for getting imaging studies. We had a child in the ED about a week ago who had an appendicitis, and I had a long discussion with one of the ped surgeons about this. There are about 3 different arms that the surgeons are looking at when they're looking at a kid with appendicitis. And depending on what arm that child is in, the management is vastly different. So, for instance, if you have a child who has an appendicitis with inflammation around the appendix, maybe some fluid around it, but the appendix is not yet burst, and especially if you have a high white count, that's something that they're going to probably take to the OR relatively quickly. If you have a phlegmon, apparently the phlegmon predicts for recurrence of appendicitis in children. If there is a phlegmon, therefore, they are more likely to go in and do an appendicitis, or do an appendectomy relatively soon. If there's not a phlegmon, in many cases, especially if it's ruptured, they will leave it alone and go in 4 to 6 weeks and kind of clean up what remains. So the imaging study is giving more information than just is there an appendicitis or isn't there. It's letting you know whether it's ruptured, whether there's a phlegmon or not, whether you got a walled-off abscess or not, all of which might change your management. So the imaging study, yes, you can make the diagnosis of appendicitis clinically, and yes, there are surgeons who take kids to the OR even without an imaging study. And I've seen our surgeons do that on rip-roaring obvious cases on the older kids, especially if it was all very, very acute. But in many cases, you have to consider these 3 different arms, and the only way you're going to be able to decide which arm to go down is to get an imaging study. So ultrasound first and then CT second if you still have a high suspicion.